Good day. Today, our lectures and topic of our lecture, ambulatory management patient with pathology of the liver. Diagnosis of the liver diseases is based on the identification of sequence development, clinical and functional syndrome, which are a combination of anamnesis, physical, laboratory, and instrumental science. Features of ambulatory practice. In ambulatory practice, it is not always possible to use all diagnosis method. Early identification basic syndrome of the liver. Damage may be adequate to determine the correct tactics of the patient. Don't use expensive method with a small amount of the information. You know that the patient with the pathology of the liver may have many different syndromes. In the beginning, we can see this basic syndrome of the chronic diseases of the liver. The first, it is a hepatomegaly syndrome, and when we do a palpation of abdomen, we can determine enlargement of the liver. Or hepatorenal syndrome, when we can palpate liver and spleen. Pain syndrome, if the patient has pain in the right hypochondrium. Very often, the first syndrome may be jaundice, maybe cytolytic syndrome. If we do laboratory examination and we can see change. The syndrome of portal hypertension and edematous ascitic syndrome. Next, the patient with the pathology of the liver may have other syndrome. It is immunoinflammatory syndrome, the syndrome of hepatocellular insufficiency, cholestasis syndrome, hemorrhagic syndrome, the syndrome of hepatic encephalopathy, the syndrome hypersplenism, hepatorenal syndrome, and many other syndromes. And also, this clinical syndrome can be observed in pathology of other organs. It is vegetative syndrome, dyspeptic syndrome, lymphadenopathy, articular syndrome, and anemic syndrome, and many other syndrome that we can determine the patient with pathology of the liver. Diagnostic criteria for clinical liver diseases are identified during the four main stages of the examination. First stage, it is interrogation and physical examination. Second stage, it is identification of a main clinical syndrome, characteristic of liver pathology, and preliminary diagnosis and survey plan. Third stage, laboratory and instrumental diagnostic of the main syndrome and the final diagnosis. And fourth stage, patient monitoring to confirm the diagnosis and effectiveness of treatment. The first stage, initial examination of the patient, is the doctor finds subjective. It is a patient with a word of the complaints and anamnesis. At this stage, some patient manage they find out the etiology of the diseases. Acute viral hepatitis B, C, D, or contact with a such patient, blood transfusion, autoimmune reaction. It is patient may have different bleeding and chronic use of alcohol and hepatotoxic drugs, and contact with the hepatotoxic chemicals, and objective determined by your doctor features of the patient condition. Next, we must do laboratory method examination. It is analysis of the blood, analysis of the urine, blood chemistry. It is bilirubin, total protein and fraction, albumin. We must determine enzyme, transaminase, alkaline phosphatase, lipid metabolism, indicators of the coagulation, and also urea and creatinine, function of and the study function of the kidney. And also we must do markers of viral hepatitis A, B, C, D, E, and others. And if you can think about the autoimmune reaction, we must study markers of autoimmune hepatitis. Recently often used FibraMarks. This test includes 10 standard biomarkers. It is alpha-2 macroglobulin, gaptoglobin, apolipoprotein, gamma-glutamine transpeptidase, and also bilirubin, transaminases, glucose, cholesterol, and triglyceride. If we do this test, we can determine many features of this patient. We can determine fibra test and determine degree of fibrosis. We can determine active test and degree activity of the pre-process. Stiata test reveals the presence and extent of the hepatic steatosis. ASH test if the patient has present or absent alcohol liver diseases, and NASH test we can determine non-alcohol steatohepatitis present or absent. And we must determine diabetes index. It is ratio IST to ILT. If this ratio less than 1, very often it is viral hepatitis. Equal 1 or 2, this patient may have a different chronic hepatitis and degenerative liver diseases. More than 2, it is alcohol liver diseases. And you must remember that if the patient has alcohol liver diseases, increase the size of the red blood cells. And we must do instrumental method. It is ultrasound of the liver, spleen, and different vessels, especially it is portal vein. And it is FibraScan, it is elastography, and then determine a degree of fibrosis. Fibra gastroscopy, X-ray examination of the esophagus and stomach, computer tomography, scan of the liver. It is elastography, and we can determine degree of fibrosis. It is ultrasound examination, and we can determine size of the liver and size of the spleen, and also we can determine diameter of portal vein. It is a scan of the liver. It is computer tomography of the liver. And if we cannot determine what is the pathology, we must do a biopsy of the liver and then study morphological structure of the liver. Very often what we can determine in the first syndrome, what we can determine, it is hepatorenal and hepatomegaly syndrome. When we can do physical examination and we palpate liver and spleen. Diseases in which the syndrome occurs, it is liver diseases, it is cirrhosis liver, it is acute or chronic hepatitis, and maybe tumor. It may be hereditary diseases, it is hemochromatosis, Wilson diseases. This syndrome we can determine in infection diseases. It is infection mononucleosis, malaria, syphilis, tuberculosis, and many other. And very often this syndrome we can determine in the patient the diseases of the blood. It is leukopenia, leukemia, and cardiovascular diseases, and liver vascular. It is chronic heart failure and Budd-Chiari syndrome. Pain syndrome. This syndrome is observed in 60 to 70% of the patient with the liver pathology. Main pain may be continuous or intermittent. Sometimes the feeling of heaviness in right hypochondrium with radiation in the back. Pain is associated with the stretched liver capsule or biliary dyskinesia. This patient on outpatient basis can be treated long unsuccessfully for chronic gastritis or cholecystitis if the right examination is not performed. And a patient may have acute pain. Acute pain in right hypochondrium can occur with the lesion of the intrahepatic bile duct or obstruction of the duct with the stone, attack of the hepatic colic. Next syndrome, what we can see very often in the patient, it is jaundice syndrome. But there are many variants of the jaundice. So the first variant, it is hemolytic jaundice, occurs as a result of the increased breakdown of erythrocytes and the formation of bilirubin. This increase its indirect fraction. Obstructive jaundice occurs in violation of the outflow of the bile through the bile duct, the increased blood bilirubin in direct fraction, and very often increased alkaline phosphatase. If the patient has increased alkaline phosphatase, it is signs of the inflammation in bile duct. You must remember that these jaundice transaminase are normal very often. And third variant jaundice, it is parenchymal jaundice, occurs with various lesions of the liver parenchyma. It is viral hepatitis, A, B, C, and others, toxic alcohol and medications, non-alcohol steatohepatitis, autoimmune aggression, destruction of the hepatocytes occurs by the own immune system. In this type of the jaundice, total bilirubin increase and increase direct and indirect fraction in the blood, and always increase transaminase in this jaundice. With an increase in bilirubin level of more than 40 micromole per liter, the color of the sclera and oral mucosa changed. And next variant jaundice, it is functional hyperbilirubinemia. It is Gilbert syndrome, Kraglin-Nayyar first or second type, Dubbin-Johnson, and Rotter variant. Hypobilirubinemia in the Gilbert syndrome is due to a decrease of in the activity of glucuronidase transferase, and very often we can see in young men we can see this variant jaundice. How determine present or absent functional hypobilirubinemia? There are special diagnostic tests. The first test, it is a test with the fasting. After fasting, a common bilirubin increase. Next test, it is nicotinic acid. And after this acid, also a common bilirubin increase. And test with the phenobarbital. If we use phenobarbital, common bilirubin decrease in this patient. Option for the severity of the jaundice. Mild degree, when bilirubin in the blood up to 80 micromole per liter. Moderate severity, 80 to 160 micromole per liter. And severe degree, more than 160 micromole per liter. Next syndrome, it is portal hypertension syndrome. Portal hypertension, it is pressure when increase blood pressure in the portal vein. And normal pressure is near the 150 millimeter water column. If the pressure 200 or 300 millimeter water column indicates moderate portal hypertension, and if more than 300 millimeter water column and above, it is significant hypotension. Cause of the portal hypertension. Portal hypertension may be if the patient has pathology of the liver. It is liver cirrhosis or maybe alcoholic hepatitis. It is a liver vascular pathology. It is a Budd-Chiari syndrome. It is pathology of the hepatic vein, and then the patient has this syndrome. Or maybe pathology of the bile duct. It is Caroli diseases, and then this patient may have increased blood pressure in portal vein. Clinical stage of the portal hypertension. First stage, initial, preclinical. This patient has general malaise, heaviness in right hypochondrium, moderate flatulence or bloating. Second stage, moderate, compensated. The first syndrome, it is a dyspeptic disorder. It is a pain in epigastric. It is epigastric discomfort, feeling of the foulness in the epigastrium, bloating in epigastrium, early satiety, nausea, progressive weight loss, and signs of the polyhypervitaminosis with sufficient nutrition. Periodically diarrhea, but without the pain and fever, and after which the state of health improve. Third stage, it is decompensated, severe clinical manifestation with the presence of symptom and syndrome. And this patient, the patient with this stage, we can palpate splenomegaly, and we can dilation vein in abdominal wall. It is caput medusa. It is ascites, oliguria. And fourth stage, when the patient has complication, it is proponents ascites. If the patient has gastritis and gastric and hemorrhoidal bleeding, and porta caval encephalopathy. Diagnostic of the portal hypertension. If we do endoscopy and X-ray examination of the esophagus and stomach, we can determine a varicose vein of in these organs. We can do rectoramonoscopy, and also we can see varicose vein in upper rectum, and abdominal ultrasound, and we can determine portal vein, splenic and mesenteric superior vein. In this picture, we can see on the endoscopy how change the varicose vein in esophagus. Ultrasound signs of the portal hypertension. The diameter of the portal vein on the expiration normally does not exceed 10 millimeter. On the inspiration, 12 millimeter. If the diameter of the portal vein does not change during breathing, this is also a sign of the portal hypertension. Next syndrome, it is edematocytic syndrome. This syndrome is one of clinical manifestations of the number diseases. Occurs when the cirrhosis of the liver, acute alcoholic hepatitis, different tumors. It is chronic heart failure, tuberculosis, peritonitis. Really, we can see this syndrome in nephrotic syndrome, acute pancreatitis, and pathology of the thyroid gland, this myxedema, and alimentary dystrophy. Ascites is abnormal accumulation of fluid in abdominal cavity. Factors leading to the development of ascites in liver pathology. The first, it is portal hypertension. Next, it is extensive lymph formation and penetration of lymph into the abdominal cavity. If the patient has increased hormone aldosterone in the blood, and in the blood we can see decreased amount of albumin, hypoalbuminemia. Classification of ascites. There are 3 degrees of ascites. First degree, fluid in abdominal cavity, is determined only by X-ray, ultrasound, or computer tomography. Second degree, we can determine if we do physical examination and then determine present or absent in the abdominal cavity fluid. And the third degree, tense ascites. Signs of ascites. A small accumulation of the fluid is appearance does not manifest. With increased fluid in abdomen, there is a frog abdomen in the supine position. A large amount of the fluid is shown, a large increase of abdomen, tension of the skin on abdomen, varicose vein in abdominal wall, the appearance of dyspnea, umbilical hernia, and flatulence. And also, if we do percussion, we changing the percussion sound when changing position of the patient. Positive symptom fluctuation, and with intense ascites, palpation of internal organs is difficult. Cytolytic syndrome is one of main indicators of activity of process in the liver and direct signs of the hepatocytes necrosis. The level of transaminases determined the degree of activity of the inflammatory process. ALT and IST markers of hepatocytes damage, not liver dysfunction. The degree of activity of inflammatory process. Minimum when the transaminase near the 2 or 3 time than the normal. Moderate 5 or 10 time increase. And if the transaminase more than 10 times, it is expressed inflammation in this patient. Very often it is necessary continue the treatment of the patient with liver diseases and other syndromes ambulatory. The first, it is cholestasis syndrome. Is a violation of outflow of bile due to pathology process which is locates from the sinusoidal membrane of the hepatocytes to the sphincter orbit. Cholestasis syndrome occurs when parenchymal or obstructive jaundice. In this patient with the cholestasis, accumulation of the bile acid in the blood. Clinical signs of the cholestasis: it is jaundice, it is itching, a sense of bitterness in the mouth, feeling of the heaviness in right hypochondrium, increased liver, light feces, dark urine, constipation. If we do laboratory examination, we can usually see parenchymal or obstructive jaundice and increase bilirubin, and also increase cholesterol, total lipids, alkaline phosphatase if the patient has inflammation in the bile duct, and maybe markers of autoimmune liver damage. It is anti-nuclear antibody and anti-mitochondrial antibodies. Hemorrhagic syndrome. The pathological condition that develop in violation of hemostasis and characterized by increased bleeding vessels. In the liver, reduced synthesis of coagulation proteins. It is fibrinogen, prothrombin, and pathology of the vascular wall. And clinical signs of syndrome. External or internal bleeding, bruising, focal pigmentation when activated inflammation in the liver. And if we do examination of the blood, we can determine decrease thrombocytes, decrease fibrinogen and prothrombin, and factors coagulation 5 and 7. Immunoinflammatory syndrome is activation of reticular endothelial system and immune cells. In this patient, we can see parenchymal jaundice, complete blood count, it is increase leukocytes, shift to the left and increase CSAR. And inflammatory proteins content increase in the blood. It is globulin fractures and C-reaction protein. Sometimes sediment tests are used. It is Timo and Weltman test. And you must remember, if the patient has acute process, transaminase increase more than 5 or 10 times, and also increase immunoglobulin M and alpha-1 and alpha-2 globulins. And Weltman test, 3 or 4 test tube. If the patient has chronic process, transaminase usually increase more than 2 or 3 times. And then the blood increase immunoglobulin G and beta and gamma globulins. Weltman test is 9-10 test tube. Syndrome of the liver failure characterized by the decrease in all biochemical components that are produced by the hepatocyte cells. It is albumin and total protein. But if we determine albumin in gram per liter, if we can see albumin in percent, it is signs of the inflammation. And you must know about this index. Also decrease prothrombin and decrease common lipids and cholesterol. Also, we can see parenchymal jaundice and hypobilirubinemia, and also decrease 5 or 7 coagulation factors, fibrinogen and ceruloplasmin in the blood. Hepatorenal syndrome. This syndrome develops in the patient with acute or chronic liver diseases. This patient tend to define jaundice, ascites, symptom of the hepatic failure, hepatic encephalopathy, or maybe bleeding in this patient. If we do laboratory examination, increase creatinine more than 133 micromole per liter, decrease glomerular filtration and decrease sodium. In urine, we can determine oliguria, proteinuria, and many different blood cells in the urine. Hyposplenism syndrome characterized splenomegaly with a decreased function of the spleen, destruction of the blood cells in the spleen, inhibitor of bone marrow hematopoiesis. This change causes anemia, leukopenia, thrombocytopenia, and bleeding. Hepatic encephalopathy. The patient is diagnosed with a central nervous system disorder, which can be reversible. There are portosystemic encephalopathy, hepatic cellular associated with a decrease in the mass of the functioning parenchyma of the liver. Patients usually often have combined form encephalopathy. The pathogenesis of encephalopathy. Increase in blood content of toxic product enterogenous origin. It is phenols, ammonia, fatty acid, mercaptan. These substances have a toxic effect on the brain. Severe neurotoxicity has ammonia. The first stage, primary. It is characterized by initial signs of mental disorder and neurological disorder. Second stage, it is decompensation. Third stage, terminal. Patient in a SOPA and badly reacts to the stimuli. And fourth stage, it is coma. Laboratory diagnosis of hepatic encephalopathy. In the blood, we can see anemia, increased leukocytes, increased SR, and thrombocytopenia. And also azotemia, hypobilirubinemia, it is jaundice, and decrease albumin and decrease cholesterol in the blood. Also, we can determine encephalopathy if we use this test, number sequence test. And then we can determine what is the degree of encephalopathy in this patient. This variant of or number communication test, and then how much time does the patient use for this test, we can determine what is the stage of this patient encephalopathy. The tactics of the treating a patient with a liver pathology. Indication for the planned hospitalization. The impossibility of carrying out therapeutic measures in the outpatient setting. The impossibility carrying out diagnostic measures in the outpatient setting. They need the constant medical supervision at least 3 times a day. And in effectiveness of outpatient treatment of the patient. Basic therapy of diffuse liver diseases include the first, it is a diet with restriction of salt, and we can use vitamin and others. And medication. The first group, medication, normalize gastrointestinal tract. It is antibiotics, it is probiotics, prebiotics, enterosorbents, and enzyme preparation, prion, pancreatine, fistal, and other. Next group, it is hepatoprotectors. Now we know many variant hepatoprotectors. The first, it is hepatoprotectors of the plant origin. Second, it is a preparation based on the adamethionine. Next, it is preparation of the bile acid, ursophalic and henofalic. Next, it is essential phospholipids. It is essential HEPA. And animal origin medication, Seripar and others, and theophyllic acid, berlithiol. Next, we must do syndrome therapy and treatment in the patient with concomitant diseases. Treatment of the different syndromic therapy. The first, it is portal hypertension. Portal hypertension, if the patient has portal hypertension, we can use vasodilators, it is nitrates and beta blocks, and vasoconstriction, it is vasopressin and somatostatin. And then we can, and also we can use diuretics, and we can decrease blood pressure in the portal way. Treatment of ascites. Ascites first degree. I used a low salt diet and control drink fluid and urine output. If we cannot help this patient and amount of the fluid don't change, we can use diuretics. Ascites in second degree. Also, we must use diet, control drink fluid, and diuresis. And diuretics, it is spironolactone and furosemide. If we use furosemide, we must use also potassium preparation. If the patient has ascites third degree, we must do total paracentesis, and then we must do albumin solution. And after this, we use diuretics drugs and control drugs, drink fluid, and diuresis. You should remember that long-term use of diuretics propounds the portacabal encephalopathy, renal failure, electrolytes imbalance. In men, the application of high doses of spironolactone leads the development of gynecomastia and erectile dysfunction. Treatment of the parenchymal jaundice. The decrease endogenous intoxication. It is enterosorbent, lactulose, enterodes, and other. And cleansing enema. Improving metabolism of hepatocytes. It is different vitamin. It is riboxine and mildronate. It is hepatoprotectors. And when the patient has cholestasis and hepatocellular jaundice, use glucocorticoids. And detox therapy. Removal of the detox substance from the body is carried out by two methods. It is intracorporal, when the removal of toxin is carried out in the natural way through the excretory system. And extracorporal detoxification is performed by the artificial removal of toxins. And intracorporal detoxification, we can use a different solution and then decrease the amount of toxin in the blood. And extracorporal treatment, if the patient has hepatorenal failure, hepatic coma, acute chronic liver failure. And in this situation, we can use plasmapheresis, hemasobsorption, and other variant of extracorporal treatments. Treatment of the Gilbert syndrome. Sparring regime without infection, stress, physical exertion, diet, patient contraindicated fatty and fried food, fasting and protein-free diet, alcohol, and resolving hepatotoxic drugs. And we can use different medication. It is Zixarin and phenobarbital. We can use enterosorbents and diuretics, albumin, different vitamins, hepatoprotectors, and choleretics in this patient. Cholestatic syndrome treatment. The first, it is enterosorbent, and then group, it is a bile acid preparation, and ursafal, henafal. This preparation, hepatoprotectors. It has choleretics, antifibrotic, immunomodulatory, and hypocholesterolemic effect. And cholestyramine, bile acid in the intestine. Next, it is bilignin, inhibitor the reabsorption of bile acid in the intestine. Rifampicin accelerated the binding of the bile acid in the blood and excretion by the kidney. And metronidazole reduce itching in the patient within a week. The effect is associated with the change in bacterial metabolism in bile acid in intestine in a patient with the cholestasis. Treatment of the hepatic encephalopathy. We can use protein restricted diet and give priority the vegetable protein. And detoxification therapy. It is infusion therapy, intestinal cleansing, method extracorporeal blood correction. And all drugs reduce ammonia can be divided into 4 groups. The first group, it is drugs that help reduce formation and absorption of ammonia in intestine. It is lactulose, it is antibiotics, and other drugs. Next group, it is drugs that connecting ammonia in the blood. It is sodium benzoate. Next group, it is a preparation increasing neutralization of the ammonia in the liver. It is glutamic acid, it is hepasol, and other hepatoprotectors. And fourth group, it is drugs that different mechanism of action. It is nootropic agents. It is improves blood circulation in the brain. It is drugs of ammonia acid, which normalize of ammonia acid composition of blood in the patient with the liver cirrhosis. And preparates of this zinc sulfate and zinc acetate if the patient has hepatic encephalopathy. And if the patient has viral etiology of we can use antiviral therapy is long and often continuous as outpatient. The first group, it is interferons. It is pegintron, pegasis. Second group, it is medicines that block viral replication. It is lamivudine, it is ribavirin, it is sofosbuvir and daclatasvir, what block replication of viral and help this patient. Next group, it is stimulated education interferons. It is amixin, cycloferon, and neovir. And fourth group, it is interleukins, and also this interleukins 2 and interleukin 12, what also change amount interferons. Infusion, we can use infusion and decoction of the herbs with antiviral effects. It is Hypericum calendula with weakly expressed choleretics and spasmolytic action. This means no to wheats and others. Prevention of non-alcohol steatohepatitis. Regular preventive examination. Timely treatment of diseases that can lead to the development of this pathology. Diabetes mellitus and other endocrine disorder, obesity, weight loss, correction of dyslipidemic disorder, reducing to use drugs that contribute to the development of steatohepatitis, antibiotics, cytostatics, hormones, and other medicine. Prevention of alcoholic hepatitis. The basis of prevention is rejection of alcohol. For mild and moderate severity of alcoholic hepatitis, its prognosis is good. Treatment is conducted by the therapist and the narcologist. With the continuous alcohol intake diseases complicate by cirrhosis of the liver, which is final stage of the alcoholic damage. Dispensary observation patient with a chronic hepatitis. Chronic hepatitis without treatment leads to the liver cirrhosis. At the minimum degree of the hepatitis activity shows examination by two therapists one or a year. With a moderate and severe process activity, 3 or 4 times a year. We must do 1 or 2 times a year laboratory examination of this patient. It is bilirubin, transaminase, alkaline phosphatase, cholesterol, protein, and other index. We must study blood of the patient 1 or 2 times, and we must determine markers of hepatitis B and C, and once a year we must do a liver ultrasound. Instruction for the patient with liver cirrhosis. Lead a normal life, normalize food, rejection of alcohol, reduce physical stress, control weight, diuresis and fluid drink, and control the frequent defecation signs. There is a direct connection with the hepatic encephalopathy. That's all.